So welcome to this e-GISE webinar that is focused on the role of PiCSO interventional transcoronary sinus technology to reduce heart failure post-ST elevation myocardial infarction. Heart failure after a myocardial infarction is quite common, affecting up to 1/3 of patients. And this is an important complication as the burden for the public health system is very important. So we are trying to develop a lot of systems that may improve the size of the infarct and thus reduce the possibility to develop heart failure. One of these systems is the PiCSO interventional transcoronary sinus technology that will be discussed during this very exciting e-GISE webinar. And I think we can start with the first talk. And I would like to introduce Dr. Azim Latib, who is the medical director of the structural heart interventional at Montefiore Medical Center in New York. He was the San Raffaele Hospital University Vita e Salute in Milan in 2008. And the title of this presentation is Clinical Outcomes of Primary PCI in STEMI and Incidence of Progression to Heart Failure. So please, Azim.
Thank you, Gianpaolo, for the kind introduction. And it's really a pleasure to be part of this symposium on a very interesting technology that I think addresses an important unmet clinical need. And I'd like to, with this presentation, maybe set the stage for what that unmet clinical need is and why we need to look at this technology in a more detailed way, and it has the potential to be an important part of what we do for primary PCI. So when we think about cardiovascular mortality and what that means, really it's changed over the last 50 years. Cardiovascular mortality was very high 50 years ago, and really there have been a number of advances that has led to a reduction in mortality, with some of those being medical therapy and more recent thrombolytics, and then the superiority of primary PCI that we see over here, and now the push really to have door to balloon times under 90 minutes. Unfortunately, if you look at the data, we seem to have really hit a plateau as far as peri-procedural in-hospital mortality for primary PCI. And we wanted to take a little bit of an in-depth look at, really what's happening as regards to mortality. So we all know that cardiovascular disease remains the leading cause of morbidity and mortality worldwide, with more than 17 million deaths per year globally. And really, in recent years, the age-adjusted cardiovascular death rate has really flattened out. We also see that there's a decline in hospital mortality for heart failure that's also slowing, and that was 6.5% in '93, now it's 2.8%. But if you look at more recent data, you really see that it really has plateaued as far as in-hospital mortality goes after myocardial infarct. I think there are a number of opportunities for us in cardiology still to improve the care of our patients, whether this is by risk factor modification, by identifying patients earlier with disease, or it's by using proven guideline-directed medical therapy that's been shown to be beneficial to our patients. But there's also, I think, a lot of patients that are not getting the right therapies. And I think really, when I get surprised when I see that, so many patients, 20 to 40% of heart attacks occur in patients with undiagnosed cardiovascular disease. We all see that in our practice. And that a lot of patients with heart failure are receiving palliative care. Well, let's look at some of the data for STEMI in particular, because it's really where this technology, I think, has the greatest potential impact. So when we think of STEMI and we look at ACS in general from the GRACE registry, we see that STEMIs account for about 1/3 of ACS presentations. One of the largest registries we have in the world that really gives us excellent long-term data and data on what's happening in a European country comes from the Swede Heart Registry. In 2018, they diagnosed in that registry, they had close to 25,000 patients with an MI. And we also found out from that from that registry, the cardiovascular disease was the underlying cause in 1/3 of patients, with ischemic causes in 1/3 of those. We see really from the Swede Heart Registry what's happened in most countries in the world, even here in the United States where I work, is that from 1995, where it was predominantly thrombolytics, we now have a strategy of primary PCI first in most countries. However, even though our outcomes have been great with primary PCI and mortality and acute mortality has decreased, there still remains the issue of heart failure occurring after myocardial infarction and as a result of myocardial infarction. And there really are different mechanisms. It could occur during the index MI due to the actual effect of necrosis and stenting. It could occur during the hospitalization related to some of the complications the patient may have related to their myocardial infarction or related to the procedure, the primary PCI procedure. And one of the areas I think we all worry about is, are we saving patients acutely from their infarct, and are they then developing heart failure much later on, months to years later, and coming back with heart failure? And so we create, even though we solve one problem, there's still this other problem of patients presenting late because of scar formation, because of ventricular remodeling. And I think that's really where, when I think of where this technology and where the issue of microvascular occlusion and the two come together are really important. So there are some data that we can use to really understand what the incidence of heart failure is following myocardial infarction. This is from the Caliber study, close to 24,500 patients with MI. And what's interesting, and I didn't know this figure myself, I have to admit, was how frequent heart failure was after myocardial infarction. In this study, almost a quarter of patients developed heart failure during a median follow-up of 3.7 years, with an incidence rate of 63.8 per 1,000 patient years. And really, if you look at this curve, you see that, this is the early curve. There's an early spike, early probably from the complications, from stenting, from necrosis. But if you look at over years, you see how this curve continues to increase. Sure, the numbers of patients on top decrease, are not as frequent as early on, but there's a continual increase in this curve of patients who present with heart failure. We do know some of those risk factors can be things like socioeconomic, age, diabetes, COPD. But I think one of the really important ones, and why we're here today, is really to talk about infarct size and microvascular occlusion as a cause. The other thing before talking about that I wanted to highlight is that when we look at the data, there's also, and this is really important, we live in a world where we need to address disparities, whether those disparities are related to sex or whether they're related to ethnic origin. We still see a lot of disparities when it comes to patients presenting with STEMI, their care, and heart failure. And this is something close to my heart as I work in the Bronx, where a lot of my patients are non-Caucasian. So you see how, patients who present, women, for example, present with much more advanced heart failure after STEMI. We see again here on the right, other data showing about patients who develop heart failure within 5 years. Again, this disparity of Black females followed by Black males, and then Caucasian females who develop heart failure earlier, more frequently than their Caucasian counterparts. Like I mentioned before, I think one of the important factors is infarct size, and we have a lot of data showing that infarct size does impact mortality. That the larger the infarct, and you see here different quartiles of infarct, as you go into the fourth quartile, the largest infarcts, patients have a higher mortality and a higher risk of heart failure hospitalization, which really does make infarct size an interesting surrogate for future heart failure and as an endpoint for our studies as we try to address this issue. What's interesting also, if you look at the subgroups of patients with large infarcts versus small infarcts, you see that irrespective of the subgroup, there is really a consistent negative impact of a large infarct on clinical outcomes. So when we think of large infarcts, I think one of the things we need to realize is that, we as interventional cardiologists need to go past just looking at epicardial arteries, and we need to start concentrating on the microcirculation and what we can do to increase myocardial perfusion at a microcirculatory level and a myocardial level. And I think we've all known about no reflow, but we think about no reflow often only when we see those advanced cases of no reflow in the cath lab with TIMI 0, TIMI 1 flow. But we often forget about the patients who may even have TIMI 3 flow, but their ST elevation doesn't resolve. Those are the patients who, if you did an MRI 24 to 48 hours later, you would still see a large infarct and a large area of microvascular occlusion. And we know that some of the variables for predicting no suboptimal flow, no reflow, are increasing age, longer stents, larger thrombus burden, low blood pressure, and also the baseline TIMI flow, probably as well as the age of the infarct and thrombus. We do know also that having poorer flow really impacts your ejection fraction, your 30-day MACE, and your 30-day risk of mortality or heart failure. So we really need to develop strategies that will address microvascular no reflow. Gianpaolo is really one of the experts in this field and has done a lot of research. And in Gianpaolo, a lot of your research and my research too for no reflow is really concentrated on only one of these variables, which has been trying to treat microvascular tone and trying to use vasodilators to improve microvascular reflow. But I think it's important for people to remember that there are a number of mechanisms that are important here, including an inflammatory mechanism, a coagulation mechanism, obstructive emboli, edema, and we really need to be able to address all of these if we want to address no reflow. We do also know that we now can measure this either in the cath lab by using IMR or by using CMR or contrast echocardiography. And which brings me to one of the studies looking at this, which really looked at survival after primary PCI for acute MI, and looking at microvascular perfusion measured using ultrasound and a mechanical index of ultrasound. Here they had close to 300 patients with STEMI who had TIMI 3 flow. So all these patients, we would call ourselves, pat ourselves on the back and say we did a successful procedure. But they used ultrasound to divide these patients into patients who had normal microvascular perfusion versus delayed versus the microvascular occlusion group. Okay. And some of the interesting things that you see, obviously things we know, patients, with the microvascular occlusion group were more likely to have grade 0 TIMI flow before the procedure. Their ST segments didn't resolve or only partially resolved. They had larger infarcts such as LAD territories. But look at the table at the bottom and look at what the impact of this is on mortality over here. 0 mortality if you have normal microvascular perfusion versus 18% if you have microvascular occlusion. Look at the impact on hospital admission for heart failure. So really this is impactful for our patients. And what was surprising for me was how 40% of patients still exhibit microvascular occlusion despite having TIMI 3 flow, and almost 80% have some sort of abnormality of their microvascular perfusion. Again, if you look and look at survival in these two groups, in these 3 groups, the blue is where you want to be, is you want to have your artery open, TIMI 3 flow, but you also want to have microvascular perfusion. Those are the patients who did the best, even over long-term follow-up. The ones with microvascular occlusion really did poorly. And this is really, these 2 groups are the patients that I think we really need, are the unmet clinical need we spoke about in the beginning, and the patients for whom we need a therapy. And for whom I really hope PiCSO is going to be that therapy. And that's why we're here today. I'm not going to spend too much time on the technology. You're going to hear so much about it from a true expert in the field, Dr. Banning. But I think this technology has the potential to decrease infarct size and to improve microvascular perfusion. It's been extremely well studied with a lot of clinical data, and I think even more clinical data now to come as the company moves into this next phase of obtaining clinical data. So I'm going to conclude here. Hopefully I've highlighted to you, and I think all of you know this, that cardiovascular disease remains the leading cause of mortality and morbidity worldwide, with heart failure being a very common cause of hospital admission. Even in our current area of primary PCI, we still see that there's this impairment of coronary microcirculation, microvascular perfusion, and this does lead to larger infarcts, which has an effect on mortality and heart failure and adverse remodeling. The rate of heart failure is probably about 20 to 25% after MI. So it's not small. These patients are coming back later, and we do need therapies to treat them acutely, and possibly mechanical therapies rather than just vasodilatory therapies. I think for me, it was surprising as I prepared for this presentation to find out that 40% of patients still exhibit microvascular occlusion despite having TIMI free flow, and up to 80% have some sort of abnormality of the microvascular perfusion. So hopefully, as we continue to now concentrate on this field of the microvascular circulation and microvascular perfusion using novel devices such as PiCSO and probably novel pharmacotherapies, hopefully this will allow us to improve patient outcomes late as well. Thank you for your attention. It's always a pleasure to talk to you, e-GISE.
So thank you, Azim, for this very interesting presentation. And I think now we can move to the second speaker, Dr. Giovanni Luigi De Maria, who is a consultant interventional cardiologist at the John Radcliffe Hospital in Oxford. And he was at the Fondazione Policlinico Universitario Agostino Gemelli in Rome. He worked with me, so it's a great pleasure to introduce him. And the title of the presentation is The Science of Interventional Transcoronary Sinus Techniques, with a focus on the PiCSO technology, including a case example. So please, Gianluigi, start your presentation.
Thank you, Gianpaolo, for your kind introduction, and thanks to e-GISE, to Marco, for this invitation today. So in the next 9-10 minutes, I will try to share with you some main concept about the technology of transcoronary sinus intervention, with a special focus on PiCSO. These are my disclosures, and mainly these are the points I will try to touch with you. So essential points about the anatomy and physiology of the cardiac venous system. They are essential to understand the main concept about transcoronary sinus intervention. And then, of course, I will move on PiCSO therapy, so pressure control intermittent coronary sinus occlusion, and I will conclude with a typical case that we had in our cath lab. So when we look at the anatomy of the cardiac venous system, we need to remind ourselves that this is a complex anatomy, and is the convergence of three main cardiac venous systems. So we have the coronary sinus system as the convergence of the Greek cardiac vein, middle cardiac vein, and small cardiac vein. But we need to remind also the presence of the anterior cardiac vein system, which is mainly in charge of draining the right and the ventricle and the right atrium into the right atrium, and the Tebesian venous system, which is a more complex venous plexus, which is indigitated with the other two systems and with the arterial system itself, and draining directly into the cavity of the four cardiac chambers. So when we look at the anatomy, then we have three interconnected venous systems, and probably the heart is the only organ in the body with three venous systems against one arterial system. And this can explain why actually 2/3 of the blood within the coronary circulation are actually contained in the venous compartment. And if we think about the macrocirculatory area, then we know that the venous side of the macrocirculatory area is actually 6 times larger than the arterial side. This is quite important because that means that it is possible technically to achieve a flow redistribution by increasing pressure on one end of the venous system, and the increasing pressure that is needed to redistribute flow actually is low, or can be low, because this is a high volume, high capacitance system. And when we increase this pressure on the venous side, we can achieve an activation of hetero or homo coronary collaterals. When we look more into the physiology, then we know that the antegrade flow in the coronary sinus in the venous system mainly happens in systole as a sort of squeezing effect coming from the myocardium. And the normal pressure within the venous system is in the range of 210 millimeters of mercury, at least within the coronary sinus, so not very different from the right atrial pressure. But what is important to understand is if we try to redistribute flow and eventually to support myocardial perfusion via the venous system, it is important that the increase in pressure has to be controlled and intermittent, because there are animal and in men studies show that if your increasing pressure goes above 60 millimeters of mercury, or if it is prolonged, this is associated with venous damage, impairment in the antegrade arterial coronary flow, and in the ventricular dysfunction. So when we look at the transcoronary sinus intervention, they can be categorized in three main groups, really. Retroperfusion, retroinfusion, and coronary sinus occlusion. If you look at the first one, retroperfusion, this consists in the delivery of arterial blood to the myocardium via the cardiac venous system. In other words, this is arterialization of the venous cardiac system. So the very first approach actually dated many years ago. It was in the pre-CABG era, so we're back in the 40s. This is the PiCSO operation. So it is a surgical permanent retroperfusion consisting in a bypass between the descending aorta and the coronary sinus, which ended up to be arterialized. The Hochberg operation wasn't very different, where the bypass went from the aorta to the great cardiac vein. So these approaches were in the pre-CABG area, and actually they were very welcome at the very beginning. But the problem is that in the very long run, this patient ended up having a very high rate of mortality because of hemorrhagic engorgement of the heart. And very simply because this is a permanent solution that actually is interfering with the venous drain of the heart. The SRP, which stands for synchronized retroperfusion, is pretty much the same concept. The only difference is that this is not permanent, and the retroperfusion within the heart takes place during diastole, so in order to allow the antegress systolic flow in the coronary sinus. But this was very difficult to be performed from the logistic point of view, and for this reason was abandoned. When we move to the retroinfusion is not very different from the retroperfusion. The only difference is that via the coronary sinus, we're trying to deliver this time a pharmacological agent rather than blood. And in theory, this is a concept that we still see today in terms of cardioplegia retroinfusion during cardiac surgery. But where our attention is actually should be focused, because this is what we are able eventually to provide in the cath lab nowadays, is the family of coronary sinus occlusion techniques. They can be balloon and non-balloon based, if we want to categorize them. The non-balloon ones, for those that are familiar, can be represented by the reducer stent, which is a stent that is placed in the coronary sinus that can produce a sort of transitory stenosis. While on the other end, we have the balloon-based and intermittent this time technique, like PiCSO and the different typology of PiCSO, let's say, which are intermittent coronary sinus occlusion, ICSO, and PiCSO, which is standing instead for pressure control intermittent coronary sinus occlusion. But why the occlusion of the coronary sinus can actually sustain reperfusion? Well, this comes from the animal model. This is a very nice study on thermography. In panel A, we have a baseline scenario, and after the occlusion of the LAD that we see in panel B and panel C, there is indeed a lower signal, so confirming the presence of induced ischemia. But if by keeping the LAD occluded, if we occlude at the same time the coronary sinus, you can see in panel D that the degree of ischemia is actually way less. And it becomes worse again when the coronary sinus is released, like in panel E. So the animal model has definitely shown, and this is a meta-analysis from a few animal models, showing that intermittent coronary sinus occlusion, so ICSO, is indeed associated with a reduction in infarct size. But how we moved from ICSO to PiCSO? So ICSO is back in the 70s. So this is the concept of intermittent coronary sinus occlusion, where the inflation and the deflation of the balloon, and the deflation is necessary to allow the venous drain, was manually and arbitrarily done by the operator, which means that it was not possible to monitor the therapy and actually check for the safety and the efficacy of it. That's why we moved to pressure observed, so it's a small p for PiCSO, intermittent coronary sinus occlusion, where this time the inflation and the deflation was still manually driven by the operator, but the operator could observe the change in pressure in the coronary sinus during the occlusion. It was fine, but it was logistically very complex, and that's the reason why now we have moved to PiCSO with a capital P, where the whole process is completely automated. In order to understand what I'm trying to refer to, essentially when we place a balloon into the coronary sinus and the balloon is the inflation position, you could see that at each heartbeat, we are going to have an increase in pressure in the coronary sinus until a plateau is reached. At that point means that the venous system has been completely filled by the inflation of the balloon, and then the balloon can be deflated for a few seconds in order to allow the normal venous drain of the heart and then preventing hemorrhage. So if we think of the mode of action, this is a paper that's been published in Eurointervention by Moll in 2018. The device technically works both in its inflated and deflated status. When the balloon is inflated, technically, blood cannot escape from the coronary sinus, and then this is redistributed back into the heart through the activation of collaterals. At the same time, this inflation generates an increase in density of the blood that can actually in itself generate a gradient between the venous and the arterial side, and then facilitate exchange, a so-called phenomenon of plasma skimming. And then at the same time, the increase in pressure is thought to exert a sort of stretching on the cilia of the endothelial cell and on the pericytes, leading to the release of vasodilators and growth factors. When the balloon is deflated, you get immediate deflation that eventually generates a sort of sucking effect that can facilitate the washout of debris and edema. And again, there is a stretch this time on the other end, again on pericytes and cilia, and new release of vasodilators factors and growth factors. If that is the theory, I will complete my presentation by sharing with you a typical PiCSO case in a STEMI patient that we had in our cath lab in Oxford. So it's an anterior STEMI. This gentleman is coming with a blocked LAD, as you can see on the screen. So we restore flow with wiring and thrombus aspiration. This was followed by pre-dilatation with a 2.5 millimeter balloon, and this is the result immediately after lesion preparation. At this point, this patient was part of a research protocol, and we did measure the index of circulatory resistance, IMR, in order to identify a subgroup of patients with high microvascular injury that could benefit more from the device. In this case, you can see the IMR was 61, 40 is the normal threshold that we can accept in a STEMI patient. And then you can see on the right-hand side, there is a long run in LAO to assess the venous face of the angiogram to identify the origin of the coronary sinus. And this can allow the introduction of the device. So the PiCSO device is introduced via right femoral vein access using a 10 French steerable guiding catheter. That you can see the two markers of the PiCSO balloon in the coronary sinus, and the video is showing you how the pressure fluctuates inside the coronary sinus during the balloon inflation and deflation. At this point, the procedure continues regularly. We keep usually the device in place for a minimum of 20 minutes, aiming for a maximum of 45 minutes. And as I said, this case was completed as per standard practice. We had to implant two stents. And after post-dilatation, this is the final result. You can see on the right-hand screen, there is a dramatic improvement in microcirculatory function after the use of the device. So we went from 61 to 22. Because of the research protocol, this patient went also for cardiac MRI scan. On the top, you have the 48 hours post-primary PCI with a large evidence of large infarct size and quite impaired systolic function. And 6-month follow-up, a dramatic improvement in ejection fraction, which technically normalized, and then infarct size that went from 44% to 21%. I think this is quite helpful in order to facilitate the next presentation that will provide more clinical insights about the data that they are becoming available about this technology. I'll thank you for your kind attention.
So thank you, Gianluigi, for this excellent and brilliant presentation. And now we can move to the third speaker, with Adrian Benning. Adrian is a professor of interventional cardiology at the John Radcliffe Hospital in Oxford. He was president of the British Cardiac Intervention Society, and he has a national profile in PCI training and advanced techniques. Adrian is one of my mentors, so it's a great pleasure to introduce him. I was in Oxford many years ago, and the title of his presentation is Current PiCSO Evidence and the Future Pipeline in STEMI Clinical Research. So please, Adrian, start your talk.
Thank you very much, Gianpaolo. It's great to be working with you again, and it's a great pleasure to be part of this GC conference and to be able to discuss this very exciting technology, which we hope will show benefit for our patients in the coming years. These are my disclosures of financial interest. I'd also like just to mention that the PiCSO Impulse system holds a CE mark for use in patients older than 18 with evidence of an anterior STEMI, with symptom onset no greater than 12 hours and TIMI flow 0 or 1 at presentation. Towards the end of this talk, I'm going to talk about some research that we've been doing in Oxford with this technology, which is outside the use of the CE mark and is part of a randomized, part of a ethically controlled trial. But this is the indication that we're going to focus on predominantly in this presentation, patients with anterior STEMI. We've heard from Azim Latib about the issues as to why there is an unmet need, the fact that for many patients with primary angioplasty, despite successful stenting, there is still severe myocardial damage, which results in scarring and remodeling, ultimately heart failure, frequent heart failure hospitalizations, impaired quality of life, and for many patients, ultimately premature death. Up to 28% of patients will develop heart failure post-MI, and this is predominantly due to suboptimal myocardial salvage. We've heard the importance of the microcirculation, and ultimately, I think, as cardiologists, it's fair to say that we spend a lot of time looking at the coronary arteries and not enough time thinking about the microcirculation in the myocardium. And I think it's really exciting that through symposium like this and the technology that's now becoming available to assess the microcirculation, we can start to think beyond the coronary arteries and into the microvasculature. As part of this, we've heard that MRI and MVO detected by MRI is an insight, but also using a pressure wire to measure IMR, the index of microvascular resistance, is also very, very helpful. As you've heard, the PiCSO technology has come from a surgical background initially, and it's gradually rolled itself into a usable technique for interventional cardiologists. But this is a technique which has a strong scientific background, and ultimately we're now working our way through to produce a technique which can be used in the emergency setting. And as you'll see from this slide on the right-hand side there, now an increasing body of evidence about its use, particularly in acute myocardial infarction. These data come from a predominantly UK study, and they look at the use of PiCSO in ACS and look at the impact of using PiCSO on infarct size. So this is infarct size measured by MRI, and you can see that in this matched study that using PiCSO reduced that infarct size by 6.9% in absolute numbers with a significant p-value. In this study, there were 22 PiCSO patients versus 58 propensity score matched controls. If we could reproduce this, we would see a 34% reduction in heart failure hospitalization, and importantly, a 25% reduction in mortality. But perhaps more importantly, when we take that data and we pick out the patients we think are particularly at risk, patients with anterior myocardial infarction and TIMI 0 or TIMI 1 flow at presentation, we see that we may actually achieve a 49% relative infarct size in these STEMI patients, 15.6% absolute risk reduction. You can see the data there on the left-hand side. Once again, this is using a reference group which we've drawn from meta-analysis by Greg Stone. Here in Oxford, we've been using IMR to triage our patients. I think it's fair to say that many patients, more than half, primary angioplasty does a good job. However, there are patients where primary angioplasty isn't going to do a good job, and we need to detect who those patients are at the time we're in the lab. And using IMR, this pressure wire technique, will allow us to identify those patients. And as you've heard from Gianluigi, a threshold of 40 is a sort of working number for us with regard to selecting those patients we think are going to do less well. So in the Oxami PiCSO study, we took patients who had an IMR of more than 40 at presentation when we'd opened the vessel, and we undertook PiCSO in a group of them. In the left-hand panel, you can see the effect of PiCSO on IMR. That initially, in black is the controls with a mean IMR of 73 and a match with PiCSO. Post-stenting, IMR falls in both groups as you improve flow, and of course, microvascular function improves with flow, although importantly, not to normal. But importantly and impressively, you see that when we took the patients back to the cath lab, 24 hours later, that the patients who'd had PiCSO had a substantial fall in the IMR down to 24.8 mean, whereas patients who received control therapy, the IMR remained abnormal more than 40. These data are then augmented by the MRI data in this same group of patients, where we see that in the control group, the 6-month infarct size was 33% versus 26% in those patients that we treated with PiCSO. So I think that hopefully illustrates to you some of the mechanism improvement that we might anticipate by using PiCSO, and what level of final outcome and infarct size reduction we might ultimately see with this therapy. More recently, we've taken some further data in Oxford and tried to look at how we might augment the initial data that we've got, both in anterior patients and also as an exploratory analysis in a small group of patients with inferior myocardial infarction. So in this group, we've got 36 STEMI patients, of whom 27 had anterior MI and 9 had inferior MI. They're matched 1 to 2 against controls. And so we end up comparing the 27 anterior STEMIs with 54 anterior STEMI controls, and our 9 inferior STEMIs with 18 inferior STEMI controls. These are the anterior STEMI data, and we've replicated essentially what we saw in the initial data that was presented at EuroPCR a couple of years ago. That's similar patients with high IMR initially, that the IMR falls significantly. But an interesting insight here is the impact on RRR, which you see in the right-hand side. This is a respiratory resistance index, which looks at vasodilatory capacity. And in this context, you want it to get better. And you see that on the right-hand side there, that following PiCSO therapy, there's an immediate improvement in RRR following PiCSO therapy. These are the data with inferior STEMI, and I'd emphasize that these are exploratory data, and this is outside the existing CE mark. But you see, interestingly, similar falls with PiCSO therapy on IMR in the left panel, and even a more substantial impact on RRR in the right-hand panel. So really quite encouraging data that perhaps this technology may not even be restricted just to the anterior STEMI patients. So Miracor are investing a lot of time and ultimately money in trying to produce a robust clinical program so that we can identify which patients will benefit potentially from this technology. And this panel, you see the projected study plan. PiCSO AMI-1 in the EU has begun. We started before the COVID crisis, and we've restarted more recently. We intend to recruit 144 patients in that study. PiCSO AMI-2 in the US will be an IDE study recruiting up to nearly 400 patients. And it's then likely there will be a French study using the Forfait Innovation as funding, and then potentially a PiCSO AMI-4. And importantly, the plan with this is to have similar trial infrastructure and similar trial endpoints so that we can condense and coalesce our patient groups and ultimately have up to 750 patients who have had this therapy, which will allow us to really dissect down who's seen the maximum benefit and hopefully work out how to deliver this therapy most effectively. So this is a little bit more data on the PiCSO AMI-1 that we're currently enrolling in the UK, and we'll be shortly rolling out in a number of European sites. 144 STEMI patients randomized 1-to-1 after flow restoration and prior to stenting. So as you saw in Gian Luigi's presentation there, the sequence of events is to open the vessel, restore flow, then do PiCSO, and then deliver stent towards the end of the procedure when PiCSO has had an opportunity to hopefully improve and condition the microcirculation advantageously. So there'll be 72 patients treated in the PiCSO group, CMR at 5 days. Obviously, we measure MACE, and then a further CMR at 6 months with obviously yearly follow-up thereafter. As I've mentioned, we've already started recruitment to this trial, and we're already back in the saddle with regard to recruiting in the post-COVID era, which is really very exciting. This slide just summarizes the level of detail, of course, that we're collecting within this trial in order to look at our primary efficacy and secondary efficacy. And there won't be any surprises to any of you, our audience, in the things that we're measuring there. So finally, before we move on, I'm just going to mention a trial that Jan de Maria is leading in Oxford, where we're looking at some of the mechanisms of PiCSO and some of the mechanisms by which PiCSO might benefit our patients, potentially beyond the STEMI indication. So we're going to look at 20 NSTEMI patients with LED disease and some impairment of left ventricular function, and measure complex hemodynamics and randomize them one-to-one in the sequence of treatments that we use with regard to PiCSO therapy and coronary occlusion. We'll be measuring some fairly complex pressure volume loops and then repeat the sequence the other way around. And from this, we hope to learn a little bit about how the myocardial energetics work and how the myocardium responds to PiCSO therapy acutely in a hemodynamic way. And you can see the level of intensity that we'll look for in these therapy patients going forward in Oxford. So I think we are essentially standing at what I hope is the threshold of an exciting period of time. We've heard that we've now reached a plateau of effectiveness for PCI therapy, and that for some patients it's suboptimal. We recognize that additional therapies are needed, but I've hinted at throughout my presentation, I think why I think targeted application is necessary. And I think by using that approach, we're more likely to demonstrate efficacy rather than looking to try and treat every patient in the same way. With regard to PiCSO, that means looking at the highest risk patients, anterior myocardial infarction, TIMI 0, TIMI 1. We've heard how PiCSO is a novel and exciting therapy that can improve outcomes for our patients, and it may have a significant role for those patients who are particularly at highest risk. And I've given you a little insight into perhaps additional applications of PiCSO, and we look forward to seeing those data as they become available. It's been a great pleasure to be part of this symposium, and I look forward to seeing you all in the flesh again soon. Thank you very much.
So thank you, Adrian, for this complete overview of clinical data about the PiCSO technology. And now we can complete this webinar with the last talk. The last speaker is Dr. Antonio Colombo. I think he doesn't need any introduction, but he is, I think, one of the father of interventional cardiology. Dr. Colombo now is Chief of Interventional Cardiology at Maria Cecilia Hospital in Cotignola, but he was a previous Chief of Interventional Cardiology, San Raffaele Hospital and Columbus Hospital in Italy. The title of his presentation is The Possible Directions for Future Scientific Research in Non-STEMI Indication. So please, Antonio, start your presentation.
Thank you very much, Professor Niccoli. Thank you to e-GISE for this opportunity, and thank you to Mirko for the support in this very interesting symposium. I conclude this series of presentations highlighting some area of possible work, possible direction for future scientific research. So this is really a field of exploration, not necessarily clinical indications. And as was highlighted before, I have no conflict of interest, but as was highlighted before, PiCSO is currently has CE mark for acute MI indication, and what I will discuss is outside the approved indications. So one area that I believe it would be interesting to explore is high-risk PCI. Of course, we have a lot of devices, not really a lot. We have 2 devices for high-risk PCI, balloon pump and the impeller. But having a third device may broaden the area of usage, and I was going to detail later on and highlight why I believe these may have unique advantages. I presented this case. It's really nothing unusual. The patient with no graft open has a significant left main disease, diffuse disease on the LAD, occluded right coronary artery, relatively depressed ejection fraction. So he was supported with PiCSO during the PCI, and here is the PCI first with rotational atherectomy, long diffuse disease on the LAD, then balloon dilatation. I don't go into the details of the angioplasty procedure. You see here was illustrated before by the other speakers, the mode of action of the PiCSO. You see that doing rotational atherectomy, you see the occlusion, the release, and stenting and ballooning with still in the lower panel with increasing the coronary pressure and the area of release. And I believe that to have a kind of retroperfusion, not necessarily, but improving perfusion in the venous system during procedures like rotational atherectomy, which kind of congested the distal bed, makes a lot of sense. So I think this has unique advantages, at least versus balloon pump. Impeller decreasing the left ventricular and diastolic pressure may mimic some approach to decrease the venous congestion. This is the LAD bifurcation treated with the final good result. On the lower hand, you see the total PiCSO quantity, which is 816 as the amount of therapy given. Currently, we remove these devices at the end of the procedure, but not necessarily you can explore the advantage of leaving the device longer. And I conclude my presentation with a real, very outside the indication case, but in this is anecdotal, but it's so dramatic that I believe is worth sharing. This is a surgical patient, a 32-year-old patient with bicuspid aortic valve, severe aortic regurgitation, normal left ventricle underwent valve repairs. 5 hours after surgery, he had severe LV dysfunction. The surgeon placed the patient on a venous arterial ECMO and also added a balloon pump. And the patient was carried in the cath lab for angiogram. You see a severely impaired left ventricular system. The coronary angiogram in a still frame is basically normal. There is no coronary occlusion at all. This was known from the angiogram before, but was confirmed by this angiogram. You see persistent severe LV dysfunction. The first day, patient did not improve at all. The balloon pump was removed, impeller was added, and he was maintained up to 15 days with this support without improvement. Then, out of desperation, I must say, we inserted the PiCSO system, and the day after the PiCSO, there was a dramatic recovery of the LV function. On the 16 days, 2 days after the PiCSO, we have a total treatment time of 4 days. PiCSO quantity 25,000, so it's really a lot. And by the day 20, the patient was weaned from the ECMO, the impeller was removed, and the ECMO was placed venous to venous, and you see here severe ventricular dysfunction after 12 hours of PiCSO and complete recovery of the LV function after the PiCSO treatment. So it's very difficult to make a statement from a single case, but when you see something so unique, your mind starts making funny consideration in dreams. So I would conclude by saying that possible unique benefit is an action of microcirculation during the procedure, which is difficult sometimes to give by a standard perfusion, even with the most sophisticated system. Selective action upon no reflow. We really do not have an effective therapy to treat no reflow. And I believe it's a really important area of exploration. And finally, there is no need of adjunctive arterial access, which in some situation may be a real benefit. So thank you again for this opportunity, and I wish you all a good meeting.
So thank you, Dr. Colombo, for this nice look at the future application of the PiCSO technology. And now it's the time to move to the question and answer session, where we will receive questions and we will answer accordingly. So we can start this question and answer session after a very nice presentation. I have my first question for Gianluigi De Maria. And Gianluigi, I would like to know how to practically integrate the system during normal activity, for example, during the night, and it's easy to use, and are there any complications? So can you comment about these practical aspects?
Of course, it's a new technology. Like any new technology, there is a learning curve. So this is undoubtful. It does require, of course, it will add extra time to your procedure, but based on the preliminary data that we have, looks like that it's kind of worth it, because it can improve, can reduce infant size, and potentially can improve clinical outcome. It is important to have the full cath lab team well engaged and well motivated in a way. So it is important to have the full support from nurses, from cath lab radiographer, cath lab physiologist, and possibly fellow. So from a practical point of view, at the end of the day, if there is, if you have a good team working behind you, can support you, this is definitely achievable. And I think this is important as an investigator, as an operator, to keep your cath lab team at the end of the day very well motivated, because it can be done. In terms of safety, the device, in all fairness, is pretty safe. When we think about the learning curve, it's not very much about preventing adverse events, but what can usually happen more frequently is a bit of displacement of the balloon, so the balloon can pop out from the coronary sinus. But other than that, the device is pretty much safe. And in fairness, in terms of major adverse events, only one case has been reported of a coronary sinus perforation, which, however, was not related with the balloon, but was instead related with the wiring of the coronary sinus. And in fairness, if you have a chat with your EP colleagues, they will confirm you that this is pretty much something that they do see as well. So in CRT implant, most of the complications usually are related with the wiring of the coronary sinus. So in summary, the device, yes, is safe, and it does require a bit of a learning curve, but however, is with a good support coming from the cath lab team, this is very, very achievable, also in the middle of the night.
Gianpaolo, your microphone's off.
Adrian, sorry. I repeat the question. So what is the best patient to be treated by this system? Because of course we cannot use this system in every case, but there is probably a patient that may benefit from this device. And the other question is, how do you explain the effect on inferior MI?
Okay, well, at the moment, as I hope to highlight in my talk, we're looking at this as a therapy for those patients where conventional therapy, if you like, open the vessel, put a stent in, anticoagulant, procedurally, and then do antiplatelet therapy isn't enough. And we've been doing a large series of patients measuring IMR, and selecting those patients is difficult unless you have the insights that IMR gives you, those that are not likely to do well. But actually, when we look through the data, anterior STEMI with TIMI 0, TIMI 1, that's a big infarct for most patients. And our results are not that good, as you heard highlighted in the first presentation. So I think that's the patient group initially that we're looking for. I would agree with Gianluigi that this extra treatment doesn't take that much longer once you get familiar with the venous anatomy, and patients tolerate it very well. This is not something to do while the patient is still in pain and wriggling around and uncomfortable. But once you, as you know yourself, once you open the vessel, the pain starts to go away, the patient is more comfortable, and often the analgesics that have been given kick in, and the patients often just go to sleep. So actually adding 20 minutes or 30 minutes to the revascularization procedure is really not too much of an issue. And we've found patients have tolerated it very well. The impact on the inferior STEMI is interesting, isn't it? But of course, you also would recognize that no reflow is a big issue in inferior STEMI. And the right coronary is an end artery. And a big right coronary with a big thrombus burden is a bit of a heart sink at 3 o'clock in the morning, because you know that there is a good chance that you will open the vessel, it'll look okay, then you put the stent in and the flow stops. So I don't really know yet how we explain that. It's an exploratory mechanism, but I think what we're seeing is that actually if we can improve the microvasculature throughout the myocardium, that there's likely to be benefit.
Very last question for Gianluigi. Please try to be quick because we have no time. Regarding cardiogenic shock, is there any experience about that for the use of PiCSO?
Not that I'm aware of. It is possible that Professor Colombo might have had some cases done a few years ago on cardiogenic shock, but there is, as I said, it's very much in terms of case report. There is no real, there are no studies or long series performed in patients with cardiogenic shock. I think this is an area where eventually the device can be explored, but probably, one step at a time. We need to prove, first of all, that we can make a difference in patients with STEMI, and then we can move to highly complex scenarios like the one for shock patients.
Okay, thank you, Gianluigi. I think we can close the session. And my conclusion is that heart failure is a great problem after ST elevation MI. So we need to try a new solution, and the use of PiCSO technology may be one mechanical approach to the problem. Of course, I agree with Adrian that the management of this kind of patients should be made by many type of efforts. And I think that if we can combine a mechanical approach with drugs and with a good system organization, probably we can reduce the impact of heart failure post-ST elevation MI. So thank you to everyone to this nice session.
Thank you.